Our research team thanks the AATS for this opportunity to review our study. We disclose off-label use of an implantable pacemaker under an IDE from the FDA. This trial was conducted with NIH R01 funding. This is an overview of the presentation. BiPACS was conducted in the context of previous studies of temporary biventricular pacing for low output states after cardiopulmonary bypass. Some such studies were promising, but results were inconsistent compared to cardiac resynchronization therapy, or CRT, accepted treatment for chronic heart failure with a 60 to 70% success rate. No previous studies of acquired heart disease employed objective pacing optimization. We hypothesized that optimized BiVP would increase cardiac index 15% versus unpaced controls on postoperative day number 1. Further, we hoped precision of operating room measurements would provide unique insights into optimization of permanent BiVP. Patients were eligible either because they were undergoing combined aortic and mitral valve surgery or for preoperative left ventricular ejection fraction less than 41% and QRS prolongation beyond 99 milliseconds. Pacing was optimized in all patients at 3 time points: 1 hour after weaning from bypass, 1 hour later after chest closure, and on the first postoperative day. Patients were randomized to continuous BiV pacing or a standard of care control group after the first optimization. The primary endpoint was thermal dilution cardiac index. Temporary pacing was implemented using an implantable pacemaker off-label under programmer control. Optimization included 7 atrioventricular delays, 2 LV lead locations, and 9 interventricular delays, or VVDs. Parameters were tested in duplicate for 10, 20, or 30 seconds in random sequence. Final comparisons were obtained after optimization. The optimization parameter was aortic flow in phase 1, mean arterial pressure in phase 2, and mean arterial pressure followed by cardiac index in phase 3. Initial studies indicated that hemodynamic stability was adequate for this study, but BiPACS proved overly ambitious for our surgeons and investigator team. After nearly 5 years and extension to a second center at UCLA, it was clear that more than an additional 5 years were needed to reach our endpoint target of 196. So the trial was terminated on February 29, 2012. 111 patients were enrolled. Primary endpoints were obtained in 47. Demographics include 74% male patients. Age average 68 years, preoperative ejection fraction 32%, and QRS duration 119 milliseconds. Surgical procedures are listed. The overall surgical mortality was 3.2%, morbidity was 33%, pacing failed in 20%. Here are the results of cardiac index measurements. 2 are from UCLA. Cardiac index from 0 to 5 liters per minute per meter squared is on the vertical axis. Patient subgroups on the horizontal axis include all, as well as 15 combined aortic mitral surgeries, 10 aortic valves with or without CABG, 8 mitrals with or without CABG, and 13 isolated CABGs. In each case, 5 cardiac indexes were measured, the highest and lowest were discarded, and the remaining 3 were averaged. Overall, cardiac index is 12% higher in paced patients versus controls. This difference is not statistically significant and is less than the predicted 15%. The only statistically significant difference by standard t-test is in the AVR patients, with cardiac index 60% higher than biventricular pacing patients. A more robust observation resulted from combining AVR and AVR-MVR subgroups, shown in the next slide. Bi-V pacing in 14 patients increased cardiac index 29% compared to 11 controls. Linear mixed model t-tests reveal that mean arterial pressure, tested following optimization in all patients in each phase, was significantly higher during Bi-V pacing versus no pacing. The benefit was 6.3% in phase 1 and 3% in phase 3. Cardiac output tested similarly increased significantly only in phase 3 by 9%. Cardiac output with AAI pacing was indistinguishable from no pacing in phase 1, but became indistinguishable from biventricular pacing in phase 3. In BiPAC substudies, we previously reported that optimum atrioventricular delay was 180 milliseconds, ranging from 90 to 270. Optimum AVD would be 20 to 30 milliseconds shorter if atrial rate were tracked rather than paced. This prolongation of atrioventricular delay was partially attributable to interatrial conduction delay. AVD optimization increased aortic flow 10%, and VVD optimization increased at 5% compared to defaults of 120 and 0 milliseconds. Between phase 1 and early ICU admission, vasoactive inotropic score increased significantly in 26 control patients while decreasing in 24 Bi-V pacing patients. Urine output was higher over the same time period with Bi-V pacing. Our recent data demonstrate a reduction in intrinsic heart rate in Bi-V pacing patients in phase 3. We believe this reflects hemodynamic benefit and withdrawal of intrinsic and extrinsic sympathetic drive. Reduced heart rate could reflect decreased propensity to atrial and ventricular arrhythmias. These data are confounded, however, by decreased dexmedetomidine in the Bi-V pacing group. In phase 1, cardiac output and mean arterial pressure increased significantly with Bi-V pacing in AVR patients, but not in patients without AVR. This further supports focus on AVR patients in the future. Our clinical transesophageal echocardiogram quality was not sufficient to demonstrate new wall motion abnormalities, so speckle tracking echo was pursued. We studied 21 patients qualifying for BiPACs but not enrolled. Unfortunately, the proportion of inadequate studies remained high, and improved imaging is needed. The data we did obtain showed no systematic patterns of wall motion abnormalities or dyssynchrony in AVR. In phase 1, we found a positive trend relating preoperative ejection fraction to increased flow during Bi-V pacing in AVR patients and a negative trend in MVR patients. Each group was too small for these associations to be statistically significant. However, interaction effect analysis confirmed a significant difference between the two groups, again suggesting an importance of loading conditions. Previously, we found no overall association between QRS shortening and BiV pacing efficacy in BiPACs, although a relation was seen in individual patients as shown. Left bundle branch block was rare in that substudy. A larger study is possible now. However, the observed statistically significant effect of BiV pacing on QRS duration shown here is opposite that of CRT, with QRSD prolonged by BiV pacing in all three BiPACs phases. Paired plots presented here demonstrate hemodynamic effects of sinus rhythm, BiV pacing, and AAI pacing. Aortic flow is shown for phase 1 and mean arterial pressure is shown for phases 2 and 3. ICU length of stay did not decrease with BiV pacing, but, as shown, pacing for an average of 18 hours was probably too short to affect an average length of stay of 4 to 6 days. In summary, the mechanism of action of pacing in this trial is unknown and apparently involves both heart rate and resynchronization. In phase 1, BiV pacing is more effective than AAI, suggesting resynchronization effects mediated by ischemia perfusion injury. By phase 3, this has subsided, and hemodynamics of BiV pacing and AAI are similar. Fundamental differences from cardiac CRT include absent QRSD shortening, rare left bundle branch block, failure of low pre-op ejection fraction or intraoperative wall motion abnormalities to predict BiV pacing response, and increased responsiveness to BiV pacing after AVR. Regarding future plans and recommendations, ongoing data analysis will include more complete evaluation of the AVR subgroup and per-protocol analysis directed at patients in whom BiV pacing was functional in all phases. Better leads and generators are needed to ensure BiV pacing activity throughout the ICU admission and include reoperations which involve the sickest patients. Self-optimizing BiV pacing would also be desirable. Additional trials are needed, stratified to focus on AVR patients. Trials should determine whether both rate and resynchronization are important and whether frequent AVD optimization is necessary. Overall, cardiac index was 12% higher in BiV pacing versus standard of care patients 18 hours postoperatively, not statistically significant. P equals 0.136. Cardiac index was 29% higher in patients undergoing aortic valve surgery. Mean arterial pressure increased with biventricular pacing versus standard of care in final comparison in all phases. Atrioventricular delay merits optimization in postoperative DDD and BiV pacing. In sub-studies, BiV pacing increased VIS score and urine output and decreased intrinsic heart rate. Further research is needed to distinguish rate and resynchronization effects in temporary pacing after cardiopulmonary bypass. Thanks to our co-investigators, and thanks for listening.